Hello guys, we're going to talk about pleural effusion in next couple of minutes. We'll talk about light criteria, we'll do pleural fluid analysis, and then we'll discuss parapneumonic effusion and empyema. So we'll start with a question. Question number 1. A 70-year-old male came with chief complaint of shortness of breath for past 2 weeks. He has a past medical history of smoking. On examination, he does not have JVD. He has decreased breath sound right lung base. S1 and S2 are normal. He has no peripheral edema. His chest sex ratio blunting of the right costophrenic, and you are concerned that he has pleural effusion, and you do a tap. So his pleural to serum LD protein is 0.7, pleural to serum LDH is 0.7 approximately. His pleural fluid LDH is 250 and serum LDH is 350. So what is the most likely diagnosis in this patient? Option A, does he have congestive heart failure? Option B, cirrhosis. Option C, nephrotic syndrome. Option D, malignancy. So most likely this is malignancy. So based on his pleural fluid analysis, most likely he has exudative effusion. Exudative effusion typically seen in patients who have malignancy or infection. Congestive heart failure, cirrhosis, nephrotic syndrome give you transudative effusion. We'll talk about that. Now, one more clue in this question is this patient has a history of smoking. So smoking predisposes to lung cancer, which can cause exudative pleural effusion. Now, one point I want to make here is if you do a pleural tap in a patient and patient cytology is negative, and if you are suspecting this patient have malignancy, you do another pleural tap that increases the sensitivity. So let's talk about pleural effusion. Most common cause of pleural effusion in the United States is congestive heart failure, pneumonia, cirrhosis, and malignancy. Now, if you do a PA film and if you see evidence of pleural effusion, most likely patient have more than 300 ml of fluid. In lateral film is very sensitive, it can pick pleural fluid up to 50 ml. Thoracic ultrasound has higher sensitivity, especially in ER or ICU setting, and CT chest with pleural phase enhancement is the diagnostic chest of choice if you are suspecting patient have pleural effusion and if you cannot quantify based on X-ray. Now this is a PA and lateral film. Here if you see patient right costophrenic angle is obliterated and patient has a meniscus sign, most likely this patient have pleural effusion. On his right apical X-ray, you see old fibrotic changes which indicate healed infection or tuberculosis. If you do tap, this patient most likely have exudative effusion. So before we discuss light criteria, let's talk about normal pleural fluid. In a normal person, 0.1 to 0.2 ml per kg pleural fluid can be seen. So if you have a 100 kg person, they can have up to 10 ml of pleural fluid. Protein is typically 1 to 2 gram, which is very low as compared to serum protein, which is almost 7 to 8. LDH is less than 50% of plasma. Glucose is same as plasma, and cell count is 1000 to 5000. And typically they're mesothelial or monocyte predominant. So very important to remember normal pleural fluid. So now let's talk about light criteria. So when you are doing light criteria, you have to measure pleural fluid protein LDH with serum protein and serum LDH. So if pleural to serum protein is less than 0.5, most likely patient have transudative effusion. If it is more than 0.5, it is exudative. Our patient ratio was 0.7. Pleural to serum LDH, if it is less than 0.6, you are dealing with transudative effusion. If it is more than 0.6, exudative effusion. Pleural fluid LDH, if it is less than 2/3 of upper limit of normal, it's transudative. And if it is more than 2/3 of upper limit of normal, most likely exudative effusion. So our patient who was smoker, who had pleural to serum protein was 0.7, pleural to serum LDH was 0.7. So patient has history of smoking, most likely patient have exudative effusion. Now let's do another question. Question number 2. A 70-year-old with chief complaint of shortness of breath for 2 weeks, past medical history of congestive heart failure, patient has JVD, he has bilateral decreased breath sound, he has peripheral edema. You start patient on IV diuretic therapy, and chest X-ray show bilateral pleural effusion. Patient's serum albumin is 3.8, pleural albumin is 1.8. You do a pleural tap. So look at his ratio. So it is 0.7 both. So which indicate most likely this patient is having exudative effusion, but his pleural fluid LDH is very low. So what does this patient have? Option A, congestive heart failure. Option B, cirrhosis. Option C, pulmonary embolism. Option D is malignancy. Most likely this patient have congestive heart failure. The reason he has congestive heart failure, although his light criteria is exudative, but he has his SAG, which is serum effusion albumin gradient, is 2. So if this gradient is more than 1.2 in a patient with congestive heart failure, most likely you are dealing with transudative effusion. Patient who have congestive heart failure, if you start them on IV diuretic and if you do pleural tap, sometime it can give you exudative effusion. The light criteria might show exudative effusion. In those cases, you calculate SAG. If the SAG is more than 1.2, most likely you are dealing with transudative effusion. So we already talked about that. Light criteria can occasionally misclassify transudative effusion as exudate in the setting of ongoing diuresis. So very important point you have to remember. Okay. Now, there are 3 main causes of transudative effusion: congestive heart failure, nephrotic syndrome, and cirrhosis. Apart from that, low albumin, and there are other conditions, but these are the most common causes of transudative effusion. Exudative effusion can be seen in infection, malignancy, pancreatitis, autoimmune disorder, post-cabbage, pulmonary embolism, drugs, and benign asbestosis. So, question number 3. Bloody fluid is often seen in malignancy, pulmonary embolism with lung infarction, trauma, benign asbestos effusion, or post-cardiac injury syndrome. Is that true or false? This statement is true. In all these conditions, you can see bloody effusion. And let's talk about cell count. So if the cell count in pleural fluid is 5,000 to 10,000, patient have bloody appearance, most likely you are dealing with either malignancy, pulmonary embolism, or asbestos, or post-cabbage. Now, if the hemothorax pleural fluid hematocrit is more than 50% of peripheral hematocrit, most likely you are dealing with hemothorax. So depending on the cell count in pleural fluid analysis, you can come up with diagnosis. So we're going to talk about all this in next couple of minutes, So in these patients who have malignancy, pulmonary embolism, and benign asbestosis, you can have bloody effusion. One important point I want to make is, if you have a patient, if you do workup and if patient have exudative bloody effusion, you should suspect pulmonary embolism, you should rule it out. One more point, benign asbestosis can give you bloody effusion. However, it is a diagnosis of exclusion. If patient has history of asbestos exposure, if they have pleural effusion, you do a tap, you have to rule out other pathology before label them as benign asbestosis. Question number 4. A 70-year-old with diagnosis of pneumonia. Patient is on appropriate antibiotic and patient is responding very well. His lateral film show less than 10 millimeter, less than 1 centimeter free flowing fluid. Next best step, what would you do for this patient? Option A, continue current management. Option B, diagnostic thoracentesis. Option C, tube thoracostomy. Option C, video assisted thoracoscopic surgery. So here the right answer is option A, continue current medical management. So this patient has parapneumonic effusion, which is not complicated. This is a less than 1 centimeter effusion, free flowing. Patient is doing better. These patients just need antibiotic, and most of the time these effusion will go away in next couple of weeks. Now, why do patient get parapneumonic effusion after pneumonia? So when you have a pneumonia, patient will have migration of excess interstitial fluid to the adjacent pleural space, and most of the time this fluid is sterile. If you do tap, it's most of the time it's sterile. Okay, so that's why if it is less than 1 centimeter, we don't do anything if patient is doing better. So let's talk about management of parapneumonic effusion and empyema. So number one scenario is non-significant effusion. If this effusion is less than 1 centimeter on lateral film, no thoracentesis is required, patient is improving, patient just need antibiotic. Now, if patient have a typical parapneumonic effusion, which is more than 1 centimeter on lateral film, less than half of hemithorax, these patients need thoracentesis. And if you do thoracentesis and if you see patient glucose is more than 60 in pleural fluid, pH is more than 7.2, LDH less than 1000, negative culture, cell count more than 10,000, this is typical parapneumonic effusion. You do a diagnostic tap, you do a serial x-ray. Most of the time patient get better, they don't need a tube or a drain or a consult with thoracic surgeon. So we talk about two things. One, we talk about a patient who had a non-significant effusion, and another scenario is if patient have a typical parapneumonic effusion more than 1 centimeter, less than half of hemithorax with pneumonia, you do a tap and the pleural fluid is sterile and patient is improving, you just do diagnostic tap and do a serial x-ray. So these are the two scenarios. So we're going to talk about another scenario in next question. So before we do that, let's go back to our table. So if patient have cell count more than 10,000 and patient have nucleated cell, poly, most likely patient have bacterial pneumonia, acute pancreatitis or lupus pleuritis. So let's do another question. Question number 5. A patient with pneumonia, you do ultrasound, patient have effusion, no septation, no loculation. Pleural tap was done for parapneumonic effusion, pleural cultures are pending. Light criteria show exudative effusion, pleural LDH is very high, 1200, so more than 1000 is very high. So pleural fluid glucose is very low, it is 20, pH is 7.1, which is very, very low, cell count is 60,000 and 70% neutrophil. What would you do for this patient? Continue current management, means continue antibiotic, you already did a diagnostic tap. Option B, repeat imaging in 2 days. Option C, this patient need tube thoracostomy. Option D, this patient need diuretic therapy. So here the right answer is option C. This patient have complicated parapneumonic effusion. This patient need a drain. So let's talk about what is complicated parapneumonic effusion. So if you see this patient pleural LDH is 1200, which is high, glucose is low, 20, pH is low, and cell count is very high. So let's talk about complicated pleural effusion. So complicated effusion typically cover more than half of hemithorax, glucose less than 20, pH less than 7.2, patient LDH is typically more than 1000, and if you do culture, they will be positive and their white cell count is more than 50,000. These patients, once you do a diagnostic tap, and if you have made diagnosis of complicated effusion, these patients need a drain. So typically we put a small drain and then you do a CAT scan of the chest in 24 to 48 hours. So what is the definition of empyema? So empyema is the presence of pus in the pleural space. pH is typically less than 7. These patients have positive culture. These patients typically need a drain tube. They need a surgery consult, and it's very high mortality. Now, difference between complicated and empyema is based on the pus and patient pH. Sometimes it's very hard to distinguish complicated effusion from empyema. So let's go back to our table. So if patient who have white cell count more than 50,000 in pleural fluid analysis, most likely you are dealing with complicated parapneumonic effusion or empyema, and most of these are poly. 70 to 80% are poly. Now I already talked about these 4 criteria, complicated pleural effusion. I want to make one more point. Empyema cultures are positive, 30 to 60% have anaerobe, so you need to cover them for anaerobe. Now, one important scenario I want to explain here is if patient have pleural fluid analysis with pH less than 7.2, glucose less than 60, LDH more than 1000, but their WBC count is less than 5000, which are lymphocytic predominant, and if patient have clinical sign and symptom of rheumatoid arthritis, most likely this patient have rheumatoid pleurisy rather than complicated effusion. So very important point to remember. So with this, we are done with pleural fluid analysis. We are done with empyema. In next couple of minutes, I'm going to talk about a diagnosis of pneumothorax and how do you do management. So I'm going to stop it here. Thank you.